In patients whose seizures cannot be controlled by medications, surgically removing the seizure onset zone, or a region of the brain where we think the seizures start, can give these patients a strong chance of seizure freedom. However, in a subset of patients, we're not able to find a seizure onset zone, and even in some patients in whom we thought we did find the seizure onset zone, they continue to have seizures even after surgery. So how can we improve outcomes for the millions of patients worldwide with treatment-resistant epilepsy? My name is Sophie Liebergall, and I'm an MD-PhD candidate at the University of Pennsylvania School of Medicine. And for my Neurosurgery 200 Capstone, I'm going to talk a bit today about cortical microcircuit mechanisms as potential biomarkers of the seizure onset zone and the impact on neurosurgical management of epilepsy patients. So to give you a roadmap of where we'll be going with today's talk, I'll start with a case study on a patient who is presenting for the evaluation of epilepsy surgery. I'll then talk about what a seizure onset zone actually is and how that definition has evolved over time and continues to evolve, the current techniques that are used to identify the seizure onset zone, and then I'll give a little bit of an intro into cortical microcircuits, and I'll finish off by talking about how cortical microcircuit activity patterns can serve as a biomarker of the seizure onset zone, and how this can impact the neurosurgical management of epilepsy patients. So for our case study today, we have a patient presenting to a comprehensive epilepsy center for an evaluation for epilepsy surgery. So our patient is a 41-year-old male with drug-resistant epilepsy. He had his first seizure 10 years ago, after which he was started on anti-seizure medications, and he was seizure-free for 6 years after that. But then unfortunately, about 4 years ago, he started having seizures every 6 months and has progressed to having seizures daily despite attempts at optimizing his anti-seizure medications. He's currently on cannabidiol, clobazam or Onfi, and cenobamate or Xcopri, though he has trialed a number of anti-seizure medications in the past. And his seizures are typically focal to bilateral tonic-clonic seizures, in which he is hyper-aware and stares for a few seconds before he turns his head to the left, and then has about 1 minute of tonic stiffening and clonic shaking. Though it's possible, based on some of his notes from his past epileptologist, that sometimes he turns his head to the right first. He had an MRI brain, this is actually a 7 Tesla MRI brain, that showed no focal cortical lesions or malformations. So it was determined that he might be a candidate for epilepsy surgery, and the patient agreed to proceed with phase 2 intracranial monitoring. He was implanted with multiple intracranial depth electrodes, so stereo EEG, 8 on the right and 8 on the left, with the goal of localizing the seizure onset zone so that it might be targeted with surgical interventions such as resective surgery or laser interstitial thermal therapy. Here are just some diagrams of the depth electrode placements in the right and left hemisphere. And then he was monitored for 1 week in the HUP Epilepsy Monitoring Unit, or EMU. So during that 1 week stay in the EMU, the patient had 2 spontaneous seizures of his typical semiology. And during these seizures, there was simultaneous onset in the leads implanted in the superior temporal gyrus on the right, as well as in leads at the posterior superior temporal gyrus and temporal parietal occipital junction on the left, at these electrodes marked in red. So the question is, where is the seizure onset zone in this patient? And to find the seizure onset zone, we must first know what we're looking for. So our conception of seizure onset zone has been a moving target that has evolved over time to reflect developments in our understanding of basic neuroscience. Early conceptualizations of the seizure onset zone aligned closely with the long history of lesion localization in clinical neurology. So Wilder-Penfield coined the term epileptic lesion as the foreign tissue itself and the structurally and functionally defined but still viable surrounding gray matter. So Penfield appreciated that seizures can arise from not only structural lesions, but also the grossly normal tissue in its vicinity. The development of 2 new technologies in the 1960s further refined the concept of the seizure onset zone. So Jasper and Rasmussen pioneered the technology of electrocorticography, or ECOG, which facilitated simultaneous electrical recordings across the surface of the brain during a large craniotomy. And in 1961, Jasper and Rasmussen published evidence that there was a strong correlation between complete removal of regions that showed spikes on the ECOG and favorable seizure outcomes. Then, in 1965, Talarak and Banqua developed targeted depth electrode placement, or stereo EEG, in which EEG signals could be recorded at multiple points in three-dimensional space. And because both ECOG and stereo EEG allow for simultaneous measurements across space, we developed an understanding of a seizure as an entity that spreads over time and across space. Hence, Talarak and Bankard defined the seizure onset zone as the site of the beginning of the epileptic seizures and of their primary organization. But then, as the popularity of resective surgery for epilepsy grew, causative conceptualizations of the seizure onset zone became more prominent as well. And as the goal of epilepsy is seizure freedom, Hans Luders, in the textbook of epilepsy surgery, defined the seizure onset zone as, quote, the area of cortex that is necessary and sufficient for initiating seizures and whose removal or disconnection is necessary for complete abolition of seizures. And then finally, in the early 2000s, our understanding of the brain has evolved beyond simple one-to-one relationships between anatomical regions and brain function. Instead, many brain functions are executed by networks of neurons that interact across disparate regions of the brain. Similarly, seizures can be thought of as a network phenomenon in which, as Susan Spencer stated, the network as a whole is responsible for the clinical and electrographic phenomena that we associate with human seizures. And as we enter the 2020s, it might be time for some new conceptualizations of the seizure onset zone, perhaps informed by for further advances in our basic neuroscience understanding of the seizure onset zone, such as through a microcircuit perspective, which I'll talk a bit about more later in this talk. So what are our current practices for identifying the seizure onset zone? This generally starts with a clinical assessment by a neurologist who will try to understand the patient's typical seizure semiology, so what the behavioral presentation of this seizure is, and if this is consistent with a focal onset seizure, so a seizure that is starting from a particular place in the brain that could then be resected or removed. These patients will get a brain MRI to look for a potential structural lesion that could be generating the seizures, as well as an EEG. An EEG is a technology where you can coarsely measure correlates of the activity of neurons in the brain. So this isn't a direct measurement of the activity of individual neurons, but is actually more of an indirect correlate of the synchronized activity of many neurons within a region. And generally, the epileptologist is looking for the first electrodes at which seizure activity is recorded. And you can often actually see abnormal activity at these electrodes even before the patient experiences the clinical seizure, so before they show behavior associated with seizure. And this EEG can take a few different forms. So the most commonly used is scalp EEG, which is a non-invasive form of EEG where the electrodes are sitting on top of the scalp outside of the skull, which is great because it's non-invasive, but it has relatively low spatial resolution. And for patients in which we want better spatial resolution to really try to get a better sense of where the seizure onset zone is, they can progress to these more invasive forms of EEG monitoring, so ECOG or electrocorticography, which, as I discussed briefly earlier, is a technique where a grid of electrodes is placed on the surface of the brain, and stereo EEG, where depth electrodes are placed in the brain at different depths so that you can record signals within the three-dimensional space of the brain. And a subset of patients will also get auxiliary scans, such as these ictal SPECT scans, where you can try to find areas of increasable blood flow during seizures. So what are the outcomes for patients with medically refractory epilepsy who have had epilepsy surgery after intracranial EEG guided identification of the seizure onset zone. The outcomes are quite good for these patients. So 34 to 74% of patients with medically refractory epilepsy were completely seizure-free after epilepsy resective surgery in a meta-analysis. And this number will depend significantly based on the center where the study was done, and also the patient population that is treated by that center. And better seizure freedom outcomes were associated with lesional epilepsy, complete or extensive resection of the lesion as assessed by the surgeon, and in patients that had no preoperative history of tonic-clonic seizures. Important to remember that the brain is not just what we see on the MRI, and actually it may be helpful for us to incorporate a more detailed microcircuit level understanding of the brain in an effort to try to improve outcomes for patients undergoing neurosurgical treatment of epilepsy. So neurons in the cortex are organized in cortical microcircuits. The most common type of neuron in the cortex are pyramidal neurons, which are named because of their shape, and they're excitatory neurons, which means that they send signals to other cells that then make those cells more likely to become electrically excited as well. And they can send signals to both nearby cells as well as to cells in other brain regions or outside of the brain. In addition to these excitatory pyramidal cells, there are also cells that are called interneurons. And interneurons only send signals to their nearby neighbors, and these signals are generally inhibitory, which means that they can prevent other cells from becoming electrically excited. And in contrast to pyramidal cells, there is a great deal of diversity among these inhibitory interneurons, and the inhibitory interneurons of the cortex can be divided into different subtypes. So in summary, the neurons in the cortex are organized in microcircuits, which are collections of neurons that communicate with each other in an organized fashion to execute a particular function, such as processing a sensory stimulus or executing a motor command. So why might an understanding of the cortex and the level of microcircuits be important for identifying the seizure onset zone in the surgical treatment of epilepsy? So first off, thinking about brain function at the level of microcircuits may better help us reconcile some of the challenges that we've had in understanding seizures using other models of the brain, such as through lesional models of seizures and network models of seizures. So in terms of lesional models of seizures, we've had this really great success with epilepsy surgery for some patients. So, cutting out a small area where you think the seizures are starting can be really effective, could be a really effective treatment. But at the same time, there's been this success of network neuroscience and graph theory in describing seizures as a phenomenon. So how can seizures both be this local phenomenon and also this dispersed network phenomenon? And perhaps understanding microcircuits can help with this because microcircuits have both long-range connections. So here, this is an image from the Allen Institute where each color here represents a single neuron originating in the claustrum of a mouse, and you can see the axon of that single neuron, so the projections that single neuron is sending. And some neurons keep their connections relatively local or close by, but this green neuron, for example, is sending its axon across almost the entire brain. Whereas at the same time, there's also these local connections within microcircuits, so cells that are really densely connected to their nearby neighbors. So convergence of these long-range and local connections in cortical microcircuits might help resolve disparities in these lesional versus network models of seizure onset. Secondly, it's likely that the activity patterns of the cortical microcircuits within the seizure onset zone are different from the activity patterns of cortical microcircuits that are in regions that are later recruited to the seizure or regions that are not recruited to the seizure at all. So identifying these specific activity patterns may practically aid in the identification of the seizure onset zone. And one piece of evidence that this may be true is the EEG signature of low voltage fast activity. So low voltage fast activity is defined as fast rhythmic activity greater than 13 hertz, occasionally up to over 100 hertz, with a low amplitude, usually less than 10 millivolts. And it's been shown in multiple studies that the proportion of patients with seizure freedom after resective surgery is significantly higher in patients with low voltage fast activity recorded in what is the presumed seizure onset zone compared to those without low voltage fast activity. And low voltage fast activity is also believed to be a marker of GABAergic interneuron activity, both from studies in animal models as well as recordings in humans. So in terms of these studies in animal models, if you inject GABA-A agonists, which are mimicking the activity of inhibitory interneurons, such as kainate or 4-aminopyridine, this actually directly triggers low voltage fast activity. Whereas if you block this GABA-A activity, you can get other preictal spiking patterns, but you won't get low voltage fast activity. Similarly, if you optogenetically stimulate the GABAergic interneurons themselves, but not pyramidal cells, this leads to low voltage fast activity. And in ex vivo brain preparations, in which you can directly record the activity of single GABAergic interneurons and pyramidal cells during a seizure-like event, low voltage fast activity is associated with tonic GABAergic interneuron firing, but not necessarily with pyramidal cell firing. And this association between low voltage fast activity and GABAergic inhibitory interneuron activity has been demonstrated in recordings from human patients as well. So in recordings from single neurons in epilepsy patients that were implanted with microwires, so patients undergoing phase 2 stereo EEG implantation, that also had implantation with special research electrodes that facilitated recording from single neurons. GABAergic interneuron activity is especially high during low voltage fast activity. So this red neuron here is an inhibitory interneuron, and these blue ones are presumably excitatory pyramidal cells. And each line here is when the cell is firing an action potential, and you can see when the low voltage fast activity is starting here, this red GABAergic interneuron is firing a lot, and the pyramidal cells nearby are relatively quiet. Another study in which patients were implanted with research microwires to record activity in single neurons further demonstrated that increased GABAergic interneuron activity is a better marker of recruitment to seizure than the activity of the majority of the excitatory pyramidal cells in the microcircuit. So here are recordings from a fast spiking GABAergic inhibitory interneuron here in red, with simultaneous recordings of the activity in nearby pyramidal cells in black here. And you can see at the presumed onset of the seizure, the activity in this inhibitory interneuron is very, very high, whereas there isn't a huge change and actually even a decrease in the firing of the pyramidal cells at the onset of the seizure before the cells transition into this burst firing mode later in the seizure. Here are some key takeaways that I hope you got from today's talk. So the conceptualization of the seizure onset zone has evolved over time from a purely localized lesion to a network phenomenon. Yet our understanding of the underlying cellular and microcircuit mechanisms in the seizure onset zone remain poor, and further research in this area could be very helpful in advancing our conceptions of the seizure onset zone. Targeted surgical resection of the seizure onset zone, as identified through structural imaging and EEG, is an effective therapy for many patients with medically refractory or treatment-resistant epilepsy. However, we're still unable to identify the seizure onset zone in a significant portion of patients, and not all patients that go on to have epilepsy surgery are able to achieve seizure freedom. So we really need to work to improve the outcomes in these patients. Existing biomarkers of good seizure outcomes from resective epilepsy surgery, such as low voltage fast activity, are associated with specific activity patterns within cortical microcircuits, such as increased GABAergic intraneural activity without concomitant increases in pyramidal cell activity. And measures of microcircuit activity, such as single unit recordings of GABAergic intraneuron and pyramidal cell activity, could serve as future biomarkers of the seizure onset zone and hopefully improve our neurosurgical treatment of patients with epilepsy. Thank you so much for your time and attention today. I want to extend a huge thanks to Dr. Brem for all of his guidance during my time on the Neurosurgery 200 clerkship. And if you want to discuss any of the things I talked about today further, please don't hesitate to reach out to me. My email is here, sophie.liebergall@pennmedicine.upenn.edu. Thanks.